So thank you for inviting me to come and speak to you today. I am a GP. I've been a GP 20 years, and when I find myself in social situations and people ask me outside work what I do, it's what I say, I'm a GP. And having this rather unusual position of practicing and being around the table when policy is being developed gives a very interesting insight into actually whether that policy is making a difference at the front line, which is frankly the only place where it matters. So the General Practice Forward View has been described by some as the biggest change management program in the history of English general practice. So it may be worthwhile reminding ourselves how we've got to a point where we need such a radical plan. Everyone here will be familiar with the problems. A decade of underinvestment at the same time as we've seen a 12% increase in acute sector spend, we've seen a 0.3% real terms decrease in investment in general practice. We have an insufficient workforce to deal with the steadily increasing demands, and actually GP morale is at its worst level since records began in 2001. So it's understandable why we're faced with so much cynicism. In fact, it's in part the frustration that I'm sure you share that led me to take on this role. However, GPs have an unrivaled capacity for adopting and adapting to change. And actually, most of what I'm going to describe to you has come from the profession itself, positive, constructive solutions, ideas, suggestions that have been brought together in the form of the General Practice Forward View. And the college itself has been particularly instrumental in helping develop this plan, and I'd like to pay tribute to the courage and bravery of Maureen and the team who've played a leading role in this. So the General Practice Forward View is complicated, and that's because the problems that general practice is facing are complicated. It's a 5-year program comprising 82 separate funded practical actions that GPs will recognize are issues that need addressing across investment, workforce, workload, and infrastructure, leading to an ability to redesign services. It does two key things. Our first priority in the coming year has to be to stabilize general practice. It has to be to stop practices handing back contracts for reasons beyond their control. Each one of those scenarios is a tragedy for patients, for practices, and for everybody. But it also needs to transform services if we're to get ahead of ever-spiraling demand. We need to leapfrog a few evolutionary steps in development and move into a space, find the sweet spot of where we can, yes, give patients a better experience of how they receive services, improve health outcomes, improve efficiency and quality, but also find our way back to a more manageable working day for GPs, one in which we feel more in control of our daily workload. So, looking at the various parts of the General Practice Forward View and starting with investment, you've already heard that there will be an extra 2.4 billion recurrently by 2021 in general practice services. And I don't think we should underestimate what a real vote of confidence this is in our services at a time of significant austerity. This is a 14% real terms increase compared to the 8% earmarked for other elements of the NHS. And whilst I understand the concerns about CCG's ability to invest, we are ensuring that we get some clarity on what the situation is by requesting that they provide us with a plan by the 23rd of December this year on their investment plans for general practice. I would argue that we're currently working under the most general practice friendly leadership the NHS has ever seen, one where they recognize that they need to break the cycle of continually bailing out hospitals while intellectually understanding that we need to invest upstream if we're to give practices not only the ability and funding, but the confidence to start investing back in their services and in their teams. And this gives you a sense of the trajectory that we have in mind in relation to the investment in general practice services going forward. I want to take a slight detour into the issue of indemnity. This has been a bit of a lightning rod for dissatisfaction across the service, with some justification, because actually at a time when successful clinical negligence claims by patients against doctors is actually going down, our indemnity fees are going up very quickly. So already actioned is the 33 million that was invested in the contract for this year. The next steps include continuing the winter indemnity scheme, but also doing further work on the out-of-hours space and how we protect doctors working in this area from further rises. But probably the biggest breakthrough is an agreement to fund distribution of resources to practices on a list basis to recognize the inflationary increases that GPs have seen in those practices. And this doesn't involve any application form or any hurdles. It will be a simple, single identifiable payment to the practice in April 2017 and April 2018. In the longer term, there is also work being done across the Department of Health, the Ministry of Justice, and NHS England to look at the claims culture and the sustainability of the increasingly heavy costs to the NHS for negligence issues. Moving on to workforce. So everyone recognizes that insufficient workforce is possibly the biggest challenge to the delivery of the general practice forward view. Nobody is in any doubt that the delivery is wholly dependent on a substantial increase in the workforce of 5,000 doctors, 5,000 allied healthcare professionals, and the ability to upskill and develop our existing teams. This is a key focus of most discussions I have with everybody at NHS England and with ministers and beyond. And in addition to the ambitions stated here on this slide, we need to go further and actually look at what are the actual measures that we're taking, particularly in relation to doctors. Just to be clear on what we mean by 5,000, this is 5,000 net, so for every doctor we lose, we need to find another 2, and this is 5,000 whole-time equivalents, so this could be several thousand more headcount by 2021. And we need to take action on 3 fronts: encouraging recruitment, making general practice attractive again, at the risk of sounding a little like Donald Trump, retain general practice, retain GPs for longer in the profession. And Maureen's already mentioned some bits about what's happening with med schools, but actually we have too much variation between the outturn of medical students joining general practice from different universities, and Professor Val Wass is doing some work with the medical schools to start understanding what recommendations we might bring forward in relation to that. The quality of a placement of a medical student within a general practice during their training is material to their decision to join our profession. And there's been announcements earlier this week in terms of expanding the places, which I'm sure you'll all be aware of. We've increased the number of training places to 3,250 a year, and whilst we don't have full coverage, we are this year on track to have the highest number of GPs in training than ever before. 250 post-CCT fellowships, the Think GP campaign, the Nothing General campaign, marketing support for practices struggling to find GPs to recruit through a CSU that's been commissioned, and further measures beyond. But one that's of particular interest is the International Recruitment campaign. And previous attempts at this haven't been particularly successful. But the work that we're doing with Lincolnshire, where we will hopefully develop a blueprint that can be used across the country, is interesting in as much as it actually involves induction in the host country around what general practice in the UK is like and what working in the NHS is like, and also some cultural training, and I have visions of them being force-fed episodes of Coronation Street and EastEnders, but actually also help and support once they come to the UK with the practical things: housing, jobs for their spouses, schooling, to help them stick and join those communities. In terms of making general practice attractive again, one might argue that all the measures within the general practice forward view are designed with that intention, but reducing workload is of particular importance. We're announcing today from NHS England some changes in the induction and refresher scheme that will hopefully reduce some of the obstacle course type nature of what's been in place prior to this, with discretion for responsible officers to understand whether someone needs to be put through that scheme, increase funding for the individuals to support them whilst they're in that process, help with their indemnity costs, help with their GMC fees, help with their criminal reference check costs. And also a case manager approach to hold their hand through that process and ensure that they can land safely within practices. But we're also working on the £20,000 bursaries, which have been pretty popular and have largely been taken up across the country, in particular areas where it's difficult to find doctors. And anecdotally, I've heard a lot of the doctors are using that £20,000 to put down deposits on properties, which would suggest that they may stick in those areas for a while. There are changes to the increases in the retainer scheme, leadership training opportunities, training hubs across the country. Possibly the biggest challenge that we face in the general practice forward view is the fact that over the age of 50, 2/3 of GPs say that they plan to leave in the next 5 years. And this is a structurally hardwired-in issue that we need to address head-on. And frankly, I don't think we've done enough about this yet, and we're planning to work with the college on how we pick this up around flexible career schemes, portfolio opportunities. We are commissioning coaching, career coaching for GPs approaching the end of their careers to ensure they're aware of all the available options. Furthermore, we're working with other disciplines within the profession. You'll be aware of the pharmacy scheme, which is being expanded across the country. We already have 450 pharmacists in post, and you may be also aware of the pharmacists becoming more involved in 111 hubs. Physician associates, an extra 1,000, return to work help for nurses, improved practice placements for nurses, the new care models, and I'll just give them a little plug, stand 105 to meet the new care models team, and what they're learning about what paramedics can do in interesting scenarios such as home visiting and supporting practices around the country, and open access physiotherapy service pilots that are going on. We also need to help develop our practice managers around developing a national network to help share best practice and develop their discipline. Moving on to workload. Now, actually, this is possibly the biggest, most challenging issue that is driving GPs away. We have increased demand, increased capacity, hospital-generated work, and disproportionate regulation, one might argue, that produces the mushroom cloud of activity that is currently general practice. So, in the way that this problem is multifaceted, the solution needs to be two. We need action on demand management, we need support within practices, we need support around resetting our relationship with hospitals, how we work collectively across practices, and how we regulate the system, and what we ask of GPs. In terms of demand management, we need a revolution in self-care. Frankly, we need to meaningfully change the threshold at which patients choose to seek health care for particularly self-limiting conditions, and support them in how they transact with us to make not only it more convenient for them, but to make it more efficient for us. Better signposting around care navigation, social prescribing, minor ailment schemes, remote management, and open access services such as physiotherapy. You'll be aware that the Vulnerable Practices Scheme has been in operation for a little while. Frankly, I don't think we've done well enough at getting the money out the door to practices that are in trouble. And actually the ambition now is to get that out the door by the end of this month. In addition, £16 million of the Practice Resilience Programme, 40 million, is due to be spent this financial year. So real help delivered in a way that is permissive and flexible to the particular scenarios and challenges that practices are facing on the ground, whether that's managerial support, operational support, clinical capacity, whatever it takes to keep the practice open and running in a way that is responsible to the taxpayer, and we have an exit strategy and a plan for how that practice recovers or merges or whatever is their right solution, but actually real meaningful support being delivered very quickly to stabilize the situation. In addition, we need to go further in the organizational development of general practices and help them learn some of the lessons from the general practice access funds and the capacity gains that they've started to see. through the National General Practice Development Program. Now, this is really key with a lot of moving parts, but actually the 10 high-impact actions may be familiar to many of you. Capacity planning tools and how we streamline back-office processes. For example, money has already been started to distribute through to CCGs for medical assistant training to help with processing clinical correspondence within practices and training for care navigation. I mentioned we need a reset with our relationship with hospitals, not only in terms of advice and guidance and trying to increase our ability to receive specialist support for complex cases remotely in a way that is efficient and slick, but also the changes to the standard contract that we've already made in relation to not bouncing back DNAs, making sure we get discharge summaries in a timely way, ensuring our patients have sufficient medication, the investigations and treatments are followed up, and they do the community referral if one is needed. And all of these are now in the current contract. We're consulting now on further changes around ensuring consultants issue fit notes if they know a patient's not going to be available for a while to return to work. Standard discharge formats so that we're not hunting through letters for the pertinent information, not asking us to prescribe beyond our expertise, and eventually sending us information that's coded that gets uploaded automatically into our clinical software. And that's changes that we're looking at instituting in the next contract. But I'm not naive enough to believe that putting it in the contract is meaningful. It may not be for some time before these changes actually start becoming business as usual in general practice. And we need to make significant, rapid strides in the work we're doing to try and accelerate that process by writing to CCGs, writing to foundation trusts, ensuring that they're aware of the changes, socializing the message, ensuring that your jobbing GP and your jobbing consultant is aware of what's expected of them in relation to these contractual changes, and reprofessionalizing that interface. And we're doing that work through a primary secondary care interface group with multiple stakeholders, including the Royal College. And making it easy for GPs to report where it's not happening to their commissioner so that they can take action. We have big opportunities around how collective working can advance how we build resilience within practices and expand our capabilities and capacity. The BMA has, in its recent issue, described locality hubs and overflow sites. And actually, what I'm conscious of is the general practice access funds have, in many places, been used as an in-hours support to local general practices for exactly that purpose. And the planning guidance that we've issued recently is giving CCGs clarity on the expectation that we have of rolling out access and capacity sites across the country so that we have a meaningful offer in each neighborhood ultimately by 2019, so that actually we can get the balance right between in-hours support for GP practices that are struggling and have reached the limit, but also a 7-day offer that is locally determined in accordance to the demands of or needs of that population. We also need to simplify the processes that we use to monitor, receive reports from, and regulate general practice. Work is happening across the GMC, NHS England, and CQC to try and streamline some of those processes. You'll have seen that some of those changes have already come into force in the general practice forward view. The CQC announced that the frequency of inspection for practices deemed good or outstanding will be reducing. We need to move away from a system of micro-incentives in how we manage general practice and more towards a holistic system of care. We must never, in all this re-engineering of the system, forget our USP as GPs. We offer complex, coordinated care in a patient-centered manner, in a person-centered manner, to patients with undifferentiated illness at scale. And actually, we must never lose the magic that happens between a doctor and a patient in the consulting room in all the changes we are proposing. I don't plan to go into any detail on the General Practice Development Program other than to let you know we're up and running. This is now in place. And actually, we have had 1,500 practices represented by a variety of organizations already express an interest in what's happening in relation to this. So this program includes the spread of innovation with websites, webinars. There's been probably somewhere in the order of 60 or 70 events nationally, and there are more coming to ensure people have the opportunity to see the whites of the eyes of the people from NHS England who are representing the organization and ask us the questions about how are we going to look up from the day job and actually develop our organizations in a meaningful way to take the benefits of what's being proposed in the general practice forward view. And we are looking to CCGs to support the backfill and the PLTs and the time and space required for general practice to do that. We've got the Time for Care program, which are the 9-month action learning sets that are starting to roll out the 10 high-impact actions, and we also have the need to hardwire in the ongoing sustainability of this change in behavior and how we improve our services continually. So there are 400 places annually for leadership change training for the next 3 years, and the first cohort has already begun. So on infrastructure, I don't plan to dwell too long on this, because all of the information is in the forward view document. However, what I would say is that actually we've probably not done as well as we should have in relation to rolling out the Estates and Technology Fund. And I think that's in part because it's been substantially oversubscribed. We are currently in the process of prioritizing the pipeline, if you like, of schemes over the next few years. So the good news is that we will have an ongoing program of support, including project management, but actually there is some delay in getting that up and running at the pace we would like. There's been an 18% increase in investment in GP IT, and this includes areas listed in the slide, but actually in combination I would categorize them into 3. Patient-facing technology that actually materially moves how patients use services. What are we doing with 30 million visits to NHS Choices every month, and can we honestly say we're channeling those patients effectively? Uptake of patient online. Interoperability is a must do. Telephone and online consultation systems, improving the back office processes. Summary care records will be rolled out to all community pharmacies within this financial year. Wi-Fi services rollout, and also developing a marketplace so other providers can start showing us the benefits of their designs. So bringing all of this together, where are we now? What might I see in my practice? And where are we going? I think it's worth stating that actually we now have the delivery and scrutiny architecture for delivering the 5-year forward view, the general practice forward view in place. That's no mean feat if you understand the processes involved. We now have an engine room so that there is a continual churn of new developments and of the initiatives that are happening in the forward view. We have the indemnity solution in place. We have clarity in the system around the planning guidance. We have, I would say, increasingly stakeholders aligning behind the ambitions of the forward view. I've already talked about most of these changes in relation to the workforce, the practice resilience program, the national development program, the investment in medical assistance and care navigation. We need to do more and faster around self-care, the standard contract changes, the GP Access Fund and the Access Hub rollout, and working across the various regulatory organizations. In terms of infrastructure, we've already touched on many of these factors as well, but lots of changes happening in that space to make it easier for that pipeline to get faster. In terms of changes in relation to practice, I think there are a mixture of things that I hope practices will start to notice, and they relate to expansion of the workforce, changing in the skill mix, the use of technology, and how we work at scale across organizations to ensure resilience for ourselves today and an ability to transform for tomorrow. So if we bring together all the bits of the jigsaw, and this is only one proposition about how the future might look, but we can imagine a world potentially in the years to come where patients are using alternative routes to access care. I've mentioned NHS Choices, but that will port into nhs.uk, which will be less transactional and more user-friendly. We're seeing an explosion in the world of apps and wearables, and what might that do to the ability for patients to send in biometric data, for practices to stop churning thousands of patients through their buildings because they have a long-term condition. The NHS has purchased 1.8 million patient activation licenses to help patients start to engage more meaningfully with care planning and personalization of care. And we have changes happening in the 111 and urgent and emergency care world. And it may be worthwhile just mentioning a couple of those. 111 online is in development, which will help patients symptom check and triage to the right service, including self-care. And also there's a bit of a revolution happening in the 111 space in terms of their actual physical services. So at the moment, your chance of speaking to a clinician if you ring a 111 service is about 20%. That's due to go to somewhere north of 50 to 60% during this reform, on the basis that actually there will be a richer range of professionals available to people when they speak. So GPs, dentists, pharmacists, mental health therapists, nurses, etc. We have opportunities around redirecting patients to other services, for example, care navigation, social prescribing, the rollout of minor ailment schemes, and open access services such as physio. There's an opportunity around new consultation models and how we route patients either through online or telephone triage systems so that we can target our resources at the patients who need us most. And also the ability to see a wider range of healthcare professionals within our services. So yes, people will still need to see the GP, and yes, we will still have an A&E. But actually, hopefully, it will be the right people seeing these services, and hopefully we'll have more time to spend with them, with their complex issues. There will be, as I mentioned, an advance in how we do advice and guidance, and possibly even connecting consultants back to the population when we refer patients so that they can actually deal with the patients directly on the basis of our request. And I think that we will start to see an increasing benefit from the rollout of the access hubs or whatever local service equivalent the Commissioner decides to purchase, with increasing capacity across our neighbourhoods of practices, multidisciplinary teams serving those communities, and specialist-facing services in those services. This is by no means set in stone. This is by no means the way it has to be, but this is an example of bringing to life some of the component parts of the forward view. Finally, I recently read somewhere that I'm supposed to be the architect of the general practice forward view. And that's probably a good thing or bad thing, depending what you think of it. But I'd like to clear that up today. The general practice forward view is the collective design of many, many people who are immensely dedicated and passionate about getting general practice back on its feet again. These are people within NHS England, within CCGs, within the Royal College of GPs, the BMA, within practices and with patient groups, and within GPs themselves. This is, I would say, to some degree, the profession's plan. People who are all joined and united in one single fact, which is that actually they all believe general practice is too important to us, to our patients, to the survival of the NHS to be allowed to fail. And I would say GPs have done an amazing job in protecting patients and staff from the recent challenges that we've had in recent times. Finally, we have a plan, but that's not sufficient. This is only a turning point. We expect to be judged on delivery, and it will require everybody's focus to make the general practice forward view a reality. Thank you for listening.